So I'd like to introduce to you Dr. Rod Pearce, who is going to talk to us about respiratory infection in residential aged care, drivers of low vaccination rate and potential solutions for change. He's a GP and a medical officer for health in the Eastern Health Authority in Adelaide and is the chair of the Immunisation Coalition and has lots to impart about this. So he has a long bio, but I won't read that in the interest of hearing more from Rod, and we'll have some short Q&As if Rod doesn't take too long. Okay, thanks.
Thank you, and welcome back. It's great to see everyone here, distinguished guests, and our Chief Medical Officer who's worked in South Australia, and good to have Michael Kidd here, and the understanding of the importance of immunisation and vaccines and what we can do. So, understand there's a green light that gives you that gives you forward. So, Chairman of the Immunisation Coalition, it's a great pleasure to have everyone here, and great to catch up with people we see every year or so at these meetings. So, I want to go run through some ideas about why rates are falling, look at our challenges, and talk about some of the things that the Immunisation Coalition is putting together to perhaps address this, and look forward to questions and engaging with everyone, because that's the way we think we're going to get changes. So 3 big killers. So influenza, still highly contagious. It's common. And then all of the subsequent medical conditions that leads to pneumonia, hospitalisations, death. And we've increasingly learnt that previously stable medical conditions get worse, and the classic example is the increased number of myocardial infarctions after influenza. So it's not just the disease, it's the loss of mobility. RSV, we're learning more about, and as someone's already suggested, we heard that respiratory infections do this, but has it been RSV? And as most of us know on the front line, it only becomes useful to know this if we can do something about it, either because we have a treatment for it or that maybe we can vaccinate. So it's a chance to get ahead of the game rather than just be reactive. So knowing what it is important, and I can't underemphasise the need to test. Don't rely on a 60% rapid antigen test, but actually get a PCR. And as John said, it's not always going to be positive, but at least it gives us a feel as to what the vaccine, what's circulating, what virus we might need to be attacking. If it's COVID or flu, we should be treating it. COVID-19 has changed everything, some good, some bad. The high mortality rate in aged care, when people die 3 weeks after they had their COVID, I wonder what to put in the death certificate. Do I put COVID because they've been fine, they've been sitting there gradually, happily wandering around the dementia ward for the last 2 or 3 years, and then they have COVID, and then 3 or 4 weeks later they're dead. You think, do I put COVID on the death certificate, or is that just a side note? Still has the high mortality, it's circulating. And the question is, should we just have every 6 months, or should it be seasonal, or should it be 6 months since the last vaccine? Creates one of the challenges. And we all understand the costs. It's the cost and the lives and the quality of life. But we're all stuck in this, to call the ambulance, to send them off to hospital, to get them back again. The hospital says, why are you sending them here? It's unwanted. Sometimes the families say no. Unexperienced staff say yes. People get isolated. They've got the decline in health. That's depressing. Staff get allocated to something potentially we don't have to do. Public scrutiny on the institution and what are you doing and why have you let this happen is always stressful. And we should understand that it's actually cheaper. So when I'm looking up the rates, and we've had a few comments about what the immunisation rates. So looking back at one of the trials done by Anne Kemp, looking at South Australian residential aged care facilities. So notice they've been called residential aged care homes now. So maybe that's a subtle reminder that we're trying to make them like homes, but most of the people know they're not. 2001, we were getting an 88% in South Australia reporting residential aged care facilities. Now, if you look at some of the national data, it talks probably around 50%. I think, Michael, some of your figures, you were saying some of your institutions, I think 31% or up to 94%, so there's a huge variation. So even people who are conscious of it and advocate for it. You can look up the 33-page report up to May the 15th, put out by the Commonwealth, and tracking it down, and noted by the RSCGP last year that there was over 100 facilities with a 10% vaccination rate. So probably around 50% flu, maybe anywhere between 10% and 90% for COVID, but that depends on how you define coverage. No one's really done RSV seriously. We've seriously thought about it, but actually implementing it is a challenge that I think our system mitigates against, because the lack of funding and the difficulty telling people they need a vaccine that they either haven't heard of, don't know the name of the virus, or don't want to pay the $300. We don't know yet. But why does it matter? And again, not only just the direct effect on our patients, but if everyone's vaccinated, then there's less spread. Staff can bring it in, move it around. Family and visitors play a role, and they spread it. So these are broadly the reasons why, which we've all reflected on and worried about and wondered about. And I'll go through these relatively quickly and then talk about possible some of the answers. So with the fatigue, burnout's affected us all, and there's a whole lot of different ways it affects us. Sometimes in the lack of energy to talk to the next person who says, why am I having this vaccine? Oh, well, it's a good vaccine. It's pretty inspiring. Yeah. We feel it down here, but actually the fact it hasn't affected us. So it's just not the residents who are sick of hearing it. It's important that healthcare providers. Done with vaccines, that's a kind of a bit of a way. Some people just look me in the eye and say, nah. And it's kind of, I don't think it's even worth the conversation, because the barriers are up, or how to get around that. And the Immunisation Coalition did a survey of 25,000 people, and we're absolutely amazed that people say, oh, flu and COVID aren't serious diseases now. And it's fascinating how that becomes the story. And we also think people have mixed up what a flu vaccine and a flu is, something that's nasty in children and there's no vaccines for, but we have got good vaccines for flu, and it's nasty in children, but people get mixed up just because COVID is not such a serious disease and there's no vaccine for children. So it's really interesting how it's changed. Mistrust and misinformation, obviously the media coverage and online misinformation. Staff are sceptical, they hear about new vaccines and the side effects, and we think the way that Kennedy and the Americans are going to push the anti-vax things is say, no, I'm not an anti-vaxxer, but I'll sack everyone on CDC and I'll appoint them with people who think that the side effects are worse than the benefits. And so, no, we're not against it, but are you really sure there's not side effects? You're sure everyone's not going to die of Guillain-Barré syndrome? You didn't tell me about that. So we think that's a strategy to undermine our confidence and undermine and to set a media discussion that is inappropriate but will make it hard for us. And staff wonder about the new vaccines, and when they hear it doesn't work that well, and why keep on producing new ones, because it's changed, and sure, it's kept in touch, and it's like, why bother anyway? There's the logistical challenges, which are really practical, which has been alluded to, and some of our approach at fixing it is headed in this direction. But vaccine scheduling, one of the things that I'm still critical of the federal government is that they did a fantastic job in helicoptering in state from the Commonwealth, purchasing and delivery to sites. Then the state says, oh, I thought the Commonwealth were doing that, and the Commonwealth, of course, says, I thought the state was doing that. So as we hand from pandemic situations where the Commonwealth stepped in and made some changes that were really fantastic, as they're stepping back a bit from the logistics of delivery, then the states are picking it up, but then they're having a bit of a fight. But I understand Mark Butler had a meeting with all the health ministers last night, and he said he was keen to miss his plane yesterday because he didn't have to go and fight health ministers tonight. I'm not sure that's quite what he said, but you got the impression that it was always a challenge to work with the states, and he acknowledged the differences between the states. If the residents aren't in the facility when you're doing a vaccine program, you've got to get back there, and sometimes because of staffing pressures, it's not always a priority. There's workforce gaps. There's a culture sometimes that makes it hard. As a casualised workforce, limited continuity, and people don't know that a particular patient either does or doesn't want to. They haven't been talking to them. Any of you worked in a facility where the staff have been there for 20 years, they know the patients, they can tell you what colour clothes they like wearing or where they like to sit or their favourite toy, and they'll say, look, they're a bit sceptical, but if you just reassure them, they'll have the vaccine. So that makes a difference. Sometimes the awareness of it, so we need to make sure staff are reminded that they need to have it. And sometimes you go to a facility and say, look, it's too busy. The federal government introduced changes that are supposed to be on the 1st of July, but we're all too busy implementing them. But that's all right, we've delayed that. It's now 1st of November, whatever the changes were, but it puts a lot of pressure. Then within the families, there's the issue of they need to be aware and support. Most families are, but they can't always get the consents. Sometimes there's language problems as well, and the family may be not willing to do something. And then inconsistent messaging, and if there's lots of people coming with advice, if there's social media, if you see something from the Federal Health Department or the State Health Department, or you get different advice about whether it's 3 months, 6 months or whatever, and there just isn't the same urgency that there was when it was pandemic in our face. And that they're real reasons, but it takes off the energy. So the solutions I'll run through fairly quickly. And the reason I'll go through them is because we all know them in our heart, but actually following them and introducing them, it takes a lot more energy, a lot more time, and some broader thinking. But essentially, we need to rebuild trust. The whole thing about having an honest and open conversation with all the barriers that we know. Be careful not to overpromise, acknowledge that we want a real discussion. We don't want to hide anything, but it's not because we're easily persuaded not to give it, but maybe have some local stories, and anyone in the Indigenous community will tell you it's the storytelling that makes the difference. Models that provide flexible vaccine programs, we've all heard about this, bringing vaccines into the facility rather than taking people out, having mobile clinics using other alternative healthcare providers. And I think one of the biggest ironies in Australia is that we've got falling vaccination rates, but we've got more healthcare providers who can give vaccines. So you've got to scratch your head and say, okay, so it's not access or not the availability of a healthcare provider who can give it. All these other things are now playing and pushing against us. And then once you say, right, we're coming third week or Friday the 13th, because there's nothing suspicious about that, we're going to vaccinate everyone. And then what do you do for all those people that weren't here? So you've got to have catch-ups. So that just adds to the complexity, but there's ways around it. Make it the norm that you have vaccinations, but it's also the staff that's important. And as I noted before, the vaccination rates of staff is often lower than the residents. And I think that's an interesting reflection on our own attitudes toward both our own health and, well, surely I should give it to my patients. It's like, well, why would I even think of giving it to someone if I can't do it myself? But it's an important and real issue. You hear of hospital programs that they have incentives and buses and enter into it. I'm not sure that works, but sometimes it does. But you need programs where whoever's in charge actually believes in it, and they're proud of the fact that they believe in these. Targeted education programs are useful, but it needs to be to the right audience, not only for culturally and linguistically diverse, but also to the level of the staff literacy, and that's a challenge sometimes. But lots of things specific to aged care. And we've talked about geriatricians, GPs, but whoever is the healthcare provider or the trusted person in that community, it's important that they're on side. We've talked about ways of doing it. I think the New Zealanders were talking about how they introduced this fantastic just tick the box online, but everyone over 55 said that's too hard. So paper still probably has its place. And when I do work with some committees and I tell them that they can fax a report to me, they just laugh and say, "What's a fax?" And it's like, in the medical world, faxes are real. Every hospital's got a fax machine. You've got somewhere fax numbers. But the grown-up young IT and the people who live in glass houses say no one uses them. But it's a reality in the health sector. Start talking to families early in the year and use digital platforms, but getting consent, or maybe it's part of when you arrive in a nursing home. And the ability to report and extract data we've talked about before. Some places are mandating staff vaccination coverage, and that's got mixed results around the country. I know when New South Wales about 10 years ago thought of making it mandatory to have a flu injection to work. They were afraid of nurses' strikes, and there were threats of staff striking if it was. And I guess compulsory vaccines during COVID has sensitised everyone. Make it part of accreditation standards, but we all know that sometimes that gets too big. But I think there's a place to fund any providers. So this is in the country, South Australia, looking at the sun setting, but maybe there's new sun rising about what we can do. So I think there's lots of good ideas. They've been tried in small pockets. So to look at some of those issues, the Immunisation Coalition decided that we'd do a pilot program in South Australia, and what we thought was a simple idea is we'd get together a committee of people who are giving vaccines. So we had the pharmacists, the nurses, the GPs, the primary healthcare networks, anyone in South Australia who we thought would be giving vaccines, SA Health as well. And we thought we'd run a pilot program to say what's going to help us change vaccine coverage in South Australia. And we decided that residential aged care was an easy market. We just go there and vaccinate everyone because there's 270 and you know where they are, they can't move, you know where they live, so you can get them. So let's target them. And then we thought the under 5, so we agreed we'd send a letter to all the childcare centres and say, remember that your child now has free vaccine access, so make sure they go to the GP and get it. It all seemed pretty simple. So the residential aged care thing, we got the working groups together. We thought we'd contact them all. And the idea was that this year we would just write to them all and saying, how are you vaccinating your staff? And we had this view that there'd be half a dozen models. So there'd be one GP would do it. There would be perhaps a group of GPs would do it. Maybe it would be the pharmacists that would come in. Maybe a mixture of both. It might be a nurse provider. They could contract somebody. It could be the institution that might do it. So we anticipated we'd come back with a list of 5 pretty standard ways that they would do it. And then we'd say what were the issues around that. And then you can just say, how'd you go? So we're going to ring them before the season. So we got in touch before the vaccine program was due. And it's been harder than we thought, but we're still working on it. But the idea, we hope, is that then we can contact the facilities again in a month or so, ask them how they went, what were the issues, and based on that, we're looking for some feedback, and then the plan is that we will go national after we've reflected on it, talk to the providers to see what the gaps are and what the barriers are and what problems institutions were having and what seemed to work. It's a bit more complicated than we thought, but based on that, we hope to have something to talk to the Commonwealth and the states about next year, and then nationally say this is likely to be some of the solutions, and maybe we can actually have a positive answer. So all of those concerns we've had that I've addressed, all of the potential solutions are great in theory, but actually getting out there and actually changing it, making a difference in residential aged care facility is still a challenge, a lot harder than we thought, and there's a whole range of issues, but we think we'll have a better handle on it next year and look forward to actually making a real change and maybe having a good idea of how successful certain models are, and let's have all the healthcare providers working together. So thank you.
Yeah, okay. So thank you, Rod, for finishing early. So we've got time for a few quick questions. while people are moving to the microphones, and I have to say you feel like you're a bit under the headlights here, you know, what's that, rabbit in the headlights or something expression? So I have one online question, and yeah, we'd all love this one. Is there a reason that aged care facilities don't employ immunisation nurses and hold vaccines in their facilities? Wouldn't that be wonderful?
So I guess our experience has been that it's reasonable to have an approach that's actually appropriate for that area. So you can look at a residential aged care facility 10 minutes from where we are now in the middle of the city, or you can go to regional South Australia, which might be 7 or 8 hours from here. It's going to be different for different regions, different communities, and we think that's one of the things that we should aspire to improve and acknowledge. And so the answer is a fix for everyone. So that's a good idea. It's going to fix some of the problems, but we need system-wide. So not rejecting any of the ideas, it's about what works and understanding that a solution that works could be different somewhere else.
Yeah, so we have a question. Not sure here.
No, you go.
Residential care is dogged by fee-for-service models, which basically disempower GPs to engage in anything other than occasions of service. We've put forward models, the proverbial lead balloon to the department, regarding getting a medical director type role or a clinical director, regardless of your subspecialty, into such roles to actually do some leadership. What's the future of general practice where we're basically only paying people for doing things, and we would never do the same thing to any other group? And I've trained the first 6 aged care nurse practitioners or pharmacists or anyone else. So why are we persisting with such a clearly inappropriate model?
Yeah, in fairness, I think the government has tried to look at that, and part of the reason I was talking about how COVID changed everything and there were some good things, part of the surveillance was the PHN's, primary healthcare networks, were commissioned to look after it, and the Commonwealth was keeping an eye on it, and then when they had low results, they were actually paying people to actually helicopter in and actually vaccinate it. So there was this sense that the Commonwealth were looking after it. As we transition to the routine vaccines, the unfunded vaccines, all of that sort of stuff, I think all of the weaknesses of our system, as you said, have been highlighted. And there are some models around, and that's what we were hoping, and we think we'll get out of talking to the institutions around South Australia as to what worked for them. And we think somewhere that sometimes there's a pharmacist who will do it, sometimes there's an immunisation provider within the organisations, and other people are using the people who are vaccinating a healthcare provider from the next town. So we think there's ways that we can say these models work, and we're hoping that that's what we talk to you and people around the country to say, look, we've got some evidence. You know, we've got 90% coverage using this model. In this particular circumstances, we've got 30%, and we think if we had a funded program, we would make the difference. That's what we're looking for from the work we're doing now.
Okay, we have a question from...
In response to the nurse-led services as well, I guess following on from what Michael says, a lot of the funding goes to primary care to deliver these services. So there's no resources or financial incentives for nurses to be able to deliver these services. So staff turnover is huge in these areas. Speaking on behalf of 47 regional LHN aged care facilities, we train staff, they move on or they get realigned into other positions. That's just a comment. I guess in terms of the childhood program recall reminder systems work, can we not use AIR to say it's been 6 months since you've had the COVID vaccine, can we not have this, or can we have reminders for pneumococcal vaccines or shingles vaccines or whatever? Is this something that we can lobby for AIR to send reminders to all eligible individuals, whether they're in aged care facilities, and because their home is an aged care facility, they will receive this correspondence? That's one question.
In the National Immunisation Strategy, it's talked about data, and one of the things that I think is fantastic is good data in, which I think we can now claim to have in Australia. But my view, and I think supporting your argument, is the data comes out in so many pieces and it's so fragmented. From a general practice point of view, you've got to extract the data one person at a time, and it would be great if an institution said, can you just download all of the AIR data so that I can actually see who's been vaccinated and who's due for it. But so far, and I don't know whether there's any program that's doing that.
But
You'll get a
can-
report from Sydney to say the NCIRS has looked at it and said that 30% of the population hasn't been vaccinated, but as a clinician looking at your particular practice, you will be, I don't think it's coming out, but we hope that will change. It's said to be one of the aspirations of the National Immunisation Strategy, and I'm hoping we can work with the Commonwealth to make all of that stuff extractable.
Whether it's the Commonwealth that sends those reminders, not necessarily the providers as such. And my other comment is I've surveyed the 47 aged care facilities in regional, and in terms of your pilot, happy to provide input in terms of what your pilot's done, because we've got different models as well, and the uptake and so on, if it informs your response to the Commonwealth as well.
Maybe just as a final statement, we'd be delighted, because one of the things has been actually getting people who are sitting at the table, and as Michael said, if you get the smart people sitting at the table, we'll have solutions. Actually working out where the smart people are at the time, because they're often too busy to come to the table. But we know they're out there, and every time we raise the flag and say, please help, we think we're getting a look at who's around.
I was just going to say, before you run away, Rod, we've just got a couple of online questions that are almost the same, and I think it is one of the things you've addressed, which is about consent forms in aged care facilities, and about wouldn't it be good if there could be a sort of consent form on admission or once a year or something like that, because more and more we need consent forms. It goes, I mean, I go back to the days of general practice when if the person came for a vaccination, that was considered to be consent. It was assumed you had it, but now everything needs to be written in triplicate, and you arrive and no one seems to have had time to ring the relative to get a consent.
One of the reasons I was quoting Anne Kemp in her 2001 review in South Australia, she wrote, I think, the original 1995 Australian strategy on what informed consent was, and I've got the 500-page document at home that says this is an informed consent. So I think what informed consent is something that you've got to be careful with. Streamlining works for some, it doesn't work for everyone. I think the anti-vaxxers are using the consent, make sure you're fully aware of every possible complication and someone needs to spend 3 hours talking to you about it, is a potential strategy. So I think we've got to be careful that we, but I agree, if we've got something that says there's other ways, but from a GP's point of view, if someone arrives and says, please can I have this vaccine, that's an implied consent that our lawyers tell us is informed consent.
Okay, thank you very much, Rod. There'll be an opportunity for more questions when we have the panel.